Amanda, this is Patsy. We have been here for over 16 years with Texas Children's working with neurosurgery and neurology. So today we're going to talk about referral logistics and what we do as epilepsy surgery nurse coordinators. So the key qualities of epilepsy surgery nurse coordinator need to have advanced clinical knowledge as a registered nurse, specifically in neurosurgery and neurology, have strong communication skills and interpersonal skills, strong organizational mastery, time management skills, high levels of empathy, patient advocacy, have an educator mindset, and critical thinking and strategic problem solving. Probably a lot of you are wondering, why does coordination matter with this program? It actually matters a lot because this is not a single event. Epilepsy surgery is a really long, stressful, multi-step process that often spans from months to years. It requires coordination across multiple specialties, inpatient and outpatient settings, repeated decision points. Patients and families must absorb large amounts of complex information as well as decision making and planning. Basically, the main point here is without a coordinator, it becomes very fragmented and it's very stressful and causes a lot of anxiety for our families. There's a lot of hidden complexities of a program without a coordinator. So in a program without a dedicated coordinator, there is no single person who oversees the entire process. The responsibility is spread across multiple providers. Tasks are completed, but the pathway itself is not owned, meaning no single role or individual is responsible for the epilepsy journey from start to finish. Our patients often move through the system reactively, but instead of intentionally. Major communication gaps across disciplines, tasks end up defaulting to our physicians, which ultimately leads to delays in evaluations, incomplete workups, missed surgical opportunities, increased patient and family distress, possible death, and provider inefficiency and burnout. So some of the process challenges that we face are delays in accessing outside imaging. So if we get a referral that comes in, we're having to constantly go back and forth with the outside facility to get imaging, which can delay conference. Another one is we get a lot of second urgent opinions. Our families will contact us saying, oh, we have surgery scheduled. We really want to make sure we're doing the right thing. So we have to hurry up and gather everything and try to present it before their actual scheduled surgery elsewhere. And then we have a lot of international referral barriers. This is a lot of corresponding with our international department regarding visas, travel, getting their records, communication, follow-up, financial clearance. And then we have a lot of scheduling difficulties due to limited physician availability, when this can create challenges because it prevents us from getting our families in a timely manner. Again, the reality is every program and every facility is going to face challenges. But if you have a coordinator, it's so much better for your families because we guide them every single step of the way. This is our process flow summary. Of course, your first step is going to be the referral, whether it be external, internal, or self-referral. And then we go on to phase 1. And then following that is going to be our epilepsy surgery conference. And then phase 2 if need be, then surgical planning and surgery and follow-up. The main point here is that the nurse coordinator orchestrates and will oversee each step to make sure it is completed successfully. So step 1 is our referral. Obviously, it's just the beginning. What exactly happens in the referral? We identify drug-resistant epilepsy. We obtain all the records from families in multiple institutions. Family and patient education about the evaluation process is initiated at this point. Referral conference is held with our epileptologists and neurosurgeons to determine candidacy and workup plans. And then we discuss this with the family, the recommendations. Without a coordinator in this step, referrals sit unreviewed, records may be incomplete, families may not understand the next steps, which leads to increased anxiety, and then the families also reach out a lot to us, and that ultimately leads to decreased satisfaction. Families are responsible for coordinating their own appointments, which leads to overwhelm, and oftentimes at this point, they're gonna just stop the process because it's too much. With the coordinator in this step, referrals are actively reviewed by the nurse. Records are gathered and organized and presented to the team. Patients receive early education and expectations, and all appointments are scheduled and coordinated together on 1 to 2 visits. And this also decreases anxiety and stress with the families and also for our physicians. Step 2 is going to be phase 1. Phase 1 is going to include their EMU admission, and that could be with or without SPECT. We do specialized diagnostic imaging, functional imaging, neuropsych testing, and neurosurgery and epilepsy appointments. This is a complex step because all of the tests that are ordered are sequenced. They need to be done in a specific order. And then results inform whether the patient advances or stops in the process. Any delays at this point will stall the entire pathway. Our role is to track the completion of each test, identify delays early on, communicate with the family and the team, and keeps the process moving forward intentionally. Number 3, step 3 is multidisciplinary surgery conference. The purpose for this conference is to integrate all diagnostic data to determine surgical candidacy, need for further testing, and what intervention is going to take place. Without a coordinator in this step, they're going to have missing data, cases are postponed, recommendations not clear, and they're not clearly communicated to the family. With a coordinator in this step, the cases are prepared completely, recommendations are translated into patient-centered language, next steps are immediately initiated. And then we go to phase 2 if needed. Phase 2 includes invasive monitoring, SEEG placement, or grids. Dr. Weiner said we don't really use the grids as much, but this also is prolonged hospitalization for patients, high patient anxiety and risk. Our role in this step is to do pre-procedure education. We schedule the procedure, assist with scheduling the procedure, expectation settings for the family, ongoing patient and family support, communication across the inpatient and outpatient teams. We ensure multidisciplinary surgical conference and proper documentation. Main point here is that the phase often determines whether surgery moves forward. The epilepsy care coordinator serves as the central clinical anchor during this phase 2 planning. We provide continuity, clear communication, patient-centered decision-making, ensuring safety throughout one of the most complex and invasive stages of the epilepsy care. And we have a testimony from one of our family members that practices interviewing.
They transformed something terrifying into something we could face with confidence. Her explanations were clear, her updates were timely, and her reassurance helped us breathe through the uncertainty. Because of her, we understood the process instead of feeling overwhelmed by it. She helped us feel prepared, informed, and supported at every turn, which changed the entire experience for our family.
Step 5, surgical decision and planning. This was a critical moment for our families because the patients weigh risk, benefits, and they think about life impact of the surgery. Is this really right for my child? What's going to happen? Decisions are rarely simple or immediate for them. Without a coordinator in this step, information may feel fragmented to the families, and patients may disengage or delay due to fear or confusion. With us in this step, we are able to reinforce education. We are an advocate for patient questions and concerns, and support for informed, confident decision making. Here's another testimony.
The journey towards the many brain surgeries my son has endured was wet with an angst of the unknown, but yet there was a peace known that we were giving people like our epilepsy nurse coordinator to walk my family through the worrisome moments of the unknown.
And then we go on to step 6, which is surgery, long-term follow-up. The process obviously does not just end with surgery, it keeps going. We do post-op monitoring, we like to try to track outcomes, and then ongoing relationship with the family and the patients also continues. We ensure continuity by communicating with our families regarding follow-up appointments and imaging. We try to check on their seizure status. A lot of families will reach out to us and let us know, oh, our child's having more seizures, and so we'll get with the team and we'll conference over them and figure out the next steps. And here's just a quick testimony.
Another advantage of having one main contact is that we got to know her and feel her genuine care and concerns for us.
And in summary, the coordinator is the thread through the surgical workup process. So basically, we provide complex medical knowledge and translation of medical information. We improve access to surgery by acting as a single point of contact to guide our patients through the challenging multi-step process, reduce confusion and anxiety by providing emotional and psychosocial support, provide enhanced education and support regarding the clinical process and pathway. We are a consistent, trusted presence for families and the patients. We also can help by reducing travel burdens due to bundling of tests. And then we also provide more efficient workflow due to coordinators directly addressing major bottlenecks in the process, and help to create a stronger multidisciplinary collaboration. And also, studies have shown that dedicated coordinators can help significantly increase the surgical volumes 32 to 96% in growth, and then also reduces evaluation times. So it's really important to know that our role doesn't take over everybody's spot. It actually helps to connect everybody. And just to save our jobs, we have a few more testimonies from families if we have a few more minutes. Okay.
There are numerous things that the coordinator did that are immensely valuable. One of the most valuable aspects of her being our primary point of contact for questions and scheduling. Her quarterbacking the entire process while also treating us as if we were family has massively reduced the stress and anxiety for all of us through what has been the most challenging time in our lives. Let's skip to the last one. This kind of sums it all up. Our epilepsy nurse coordinator was an angel placed on the other end of the phone from a family in Alaska who had nowhere else to turn because the answers were not available in our state. From the first time I spoke to our epilepsy nurse coordinator, I had no doubt in my mind that she was given to us to calm our hearts, answer our questions, give us hope when there was no hope over 4,000 miles away, and a person who gave her all to make sure we understood our choices. It was because of that first interaction that I made the difficult decision to send my wife and 6 sons to Texas Children's Hospital to receive an appointment that our epilepsy surgery coordinator had found us. She is the first link that gave us a glimmer of hope when we felt lost in faith, when fear was overwhelming us, knowing we needed to find help for our 6th son. There's not a moment in time that I have ever regretted calling the EMU number listed on the website, especially knowing that it was our epilepsy nurse coordinator who answered. The ranking that is given out each year for top children's hospitals and departments like neurosurgery and neurology is not by happenstance, but it is due to the teamwork from everyone involved in the care of kids like my son. To sum up my writing about our epilepsy nurse coordinator, we would not be here where we are without her and the rest of the team.
Thank you.